I've been tasked with to discuss a few cases about a very specific entity, which is commonly observed, usually in an older age group than the younger age group, where we see the disc prolapses that Dr. Shyam showed. That is a single level unilateral soft disc. So here I am about to discuss the radicular pain, radiculopathies that happen in the presence of a pre-existing spondylosis, whether in the presence or absence of. So there are several dilemmas. I will not go into the details about that. We can discuss this as we go through the cases. So I'll try to squeeze in two cases here. So the first case is a 68-year-old male. He is a retired college professor who leads a very active lifestyle. He goes and plays golf, and he's been having this long-standing neck pain that is typical of cervical spondylosis, postural or exertion, and pretty well controlled with physiotherapy and very minor lifestyle modifications. Now, he recently took a long distance road travel, after which the pain worsened. And now in the last 4 months, he has started developing a radiating pain in the left upper limb. It was mild to start, was constant with intermittent aggravation. But however, since it has worsened last 1 month, and it is interfering with his active lifestyle. So it is predominantly limited to left lateral aspect of the arm, distal forearm, and lateral aspect of the hand on the left side. So there is no numbness, weakness, gait disturbances, no motor sensitivity presentation. And when he came, I'll go in the order, he came with an MRI to us, but we got the X-ray done later on. So this is a X-ray. I would now go to the panel. Dr. Shiraz, we'll start with Dr. Shiraz here. So can you just elaborate on the X-ray? So what would you look at these chronic patients who come with neck pain, long-standing neck pain, and an acute onset radiculopathy? So are there some signs that we can pick up on the X-ray?
Main thing I try to obviously 7
Yeah, I think that's a wonderful point. So probably even the C6-7 though appears more degenerated on an X-ray. So the acute symptoms that the patient has presented with probably are unlikely to be due to the C6-7 because it's already stabilized, it's already out of use. There is less chance that it may have an acute fragment, and it's more likely that an adjacent segment where there is showing less signs of degeneration is probably responsible for fragment for the acute. There is an acute fragment that we are dealing at C5-6. Also explained by the radicular symptoms that the patient has. Dr. Ayush, so how frequently do you rely on? Of course, we went ahead and got an MRI done. So in these MRIs, how often would you rely on the foraminal sagittal view? What would you like to look at? And can you just elaborate to the younger audience, like what are the points that we see on a lateral sagittal MRI view?
So basically, these cases, as rightly pointed out, is acute and chronic. So there are a lot of things going on. It will have a lot of things. So best what I do is you go through the entire scan. I don't, because you have to see the patient as a person from head to toe. Similarly, I won't rely on one single view, especially when a lot of things are going on, to come to a conclusion.
So okay, then we'll go ahead with the mid-sagittal as well as parasagittal view. So this is the picture on the mid-sagittal sections, as well as this is on the left foraminal view.
So basically, the best, what we do at least, is to go through the entire scan. You go from up to down, from one end to best is to go through.
Yeah, we will come to the axial sections. I have it. I will show you. So, but can you just tell us what we can see?
If you look at the foraminal side, you of course the left side. And you see the root, and I think just the level above the degeneration that I think is supposed to be 5, 6, if I can count it right, because it's not marked here. The foramen looks to be the most stenotic, and you can, because the space, or because of the kyphosis and even there is some amount of disc which is coming more on the left side. It is getting
Yeah.
compressed.
So,
looks
definitely there is
yeah,
a chronic disc at the C67, and
the
here
level,
there
level.
appears to
So
be. Yeah.
you have both the kyphosis and the small amount of disc. So in a kyphotic spine, even a small amount of disc could be a bigger culprit than what
Yeah.
it's
So,
supposed to.
Amit, so in such cases in an MRI, how would you differentiate? Like this patient has a combination, we know that, of chronic symptoms and an acute. On MRI, what sequence would you say, or how would you say to differentiate between a chronic component, which has been there for quite some time, and an acute?
Clinical presentation is one thing, which dermatome and which myotome is affected. One. I would also like to have a look at the axial scans before making final decision. And in each kind of cases, when if I'm going ahead with the surgery, then I would like to get a CT, especially for the C6, and how much is the disc is calcified, and so that I can be mentally prepared. So as we can see, C5, 6, there is a fairly large disc occupying the foraminal area, kind of matching with the patient's symptoms. But at C6, 7, there is bilateral stenosis in the foraminal area, which again can be contributing to the patient's. So,
yeah. So definitely, quickly going ahead with the case. So this is the clinical presentation. So now comes the question: now what next? So you continue conservative option at that particular time, because patient has been having these symptoms for 4 months. Obviously, because the patient doesn't have any deficit, a very small laterally located disc herniation, acute fragment. So, and we have already discussed in the previous case the role of a root block. And of course, in this case, we continued conservative treatment. There was no improvement. There was further worsening in 10 days' time, and he came afterwards with a left 6 hyposthesia with a mild elbow extension. Now he's got a disc prolapse, an MRI that is done 10 days back. So what is the reason? What is the threshold, Dr. Vivek? How would you evaluate this patient from now onwards? Would you immediately go in and get a new MRI done, because the previous MRI is 10-day-old? We already know there is an acute left-sided
So
fragment.
definitely not, sir. Means I was expecting the same scenario to get worsened. If it, I guess 5, 6, and if it's matching with the clinical symptoms, I won't repeat the MRI.
Yeah.
If any new deficit happens, then definitely yes.
So what would be your next options? At
Root
this
block,
particular-
for sure, root block.
At this condition. So what is the reason? Why would you select a root block? The presence
There
of
is
a
not much
hyposthesia.
deficit, and he was managing with it since years together. It's only a short history of almost 4 months, and its main complaint is pain. His main complaint is pain rather than deficit. There is no red flag. It's not that great deficit. Then definitely root block is worth trying.
Yeah, thank
If
you,
I could
sir.
have been at his scenario,
Sure.
I will.
Yeah. But then, sir, so what is the role of steroids in these cases? Recommend giving oral steroids for, apart from the root block, with or without the root block?
Yes, sometimes, but of course, in the elderly population, you watch out for diabetes. Youngsters, less chance of having diabetes. And those patients, I do use oral steroids if the initial intensity of the pain is very high, and with a small amount of neurological deficit, what you described, slight elbow weak. If there is no contraindication, along with rest, which I always like to do, I would use oral steroids prior to using epidural steroids.
So, Ram sir, I know that now we have decided that to manage these patients with conservative options. So when would you say in these particular patient recommend a surgery? Because the patient has now developed a recent onset deficit, which is early in the course, it is mild as of now. So would you wait? If so, for how long? How would you monitor? What would be your protocol?
From the first day that I've seen this patient, there'll always be an informed, shared decision making and moved forward together. Hence, surgery is not going to come out of the blue. Surgery is something. Having said that, if we reach he feels everything that we have done together. Maybe whatever his level, then I would need. At that point, again, the decision making also rely on response if nerve root did have temporary and under the where we knew that if of the two, 5, 6 is the major offender and the major culprit, 6, 7 is not a major, then the discussion would be. If, however, it's equivocal, that decision, 5, 6.
Just
and
last
6,
one
7.
last pearl of wisdom from you, sir. Again, so continuing, this was the second case. Now, patient has a right C radiculopathy. There is 5-6 acute disc prolapse, as we can the foraminal fragment there on the right side. See, spinal cord intrinsic changes, which the patient is not symptomatic for. So what would you do in these kind of cases? An asymptomatic adjacent level disc prolapse with cord compression and intrinsic change. Patient has presented with a unilateral radiculopathy at an adjacent level. So what would be your strategy? Like, would you treat both the levels? Would you just do a foraminotomy at one level in these cases? Because it has not responded to conservative treatment. I have not gone through the case in detail.
The cord signal per se is something that I cannot predict an improvement whatsoever with whatever I do. And I would go for the least invasive and the minimal. I would attack just one point rather than do the whole. So I would, again, it would be a counseling, and that's most.
So anybody else from the panel, would you want to counter that? Would you like to do both levels in these particular cases where there is a cord signal changes? Any opinions? Just one last comment.
I would go for next level as well, where the cord signal is there, along with taking care of the. I'm doing a surgery. I'm right there. Let's get it over with.
Thank you so much. Just to summarize, I think treating the symptom is the most important. Unilateral radicular pain can be managed conservatively in most cases when surgery is required. Again, targeted posterior foraminotomy is one of the best options. Of course, in presence of adjacent segment, the decision whether to intervene from anterior and remove the entire disc and fuse depends upon the patient's symptom, presence or absence of myelopathy, as well as how severe the adjacent level segment changes are. Thank you so much.